Welcome to Have More Babies. Today we're going to dive into something really important for parents of young infants, especially those who might be considered high risk.
That's right.
We're talking about the guidance for using Palivizumab,
hmm
which is a medication to help protect certain babies from getting seriously ill with RSV, Respiratory Syncytial Virus.
Yeah, and the information we're digging into comes from the Georgia chapter of the American Academy of Pediatrics, specifically a communication from September 2016.
Right, and that communication actually just reiterated guidance they'd already put out back in September 2014, so consistent advice there.
Exactly. So our goal today is really to unpack who this is for and when it's recommended. It's all about preventing those severe RSV cases that land vulnerable babies in the hospital.
And it's worth stressing, isn't it? This isn't a recommendation for all babies.
No, definitely not.
We're focusing specifically on those infants identified by doctors as having specific risk factors.
Yeah.
So maybe you could start us off with a quick overview. What is RSV, and why is it a bigger deal for some babies than others?
Sure. So RSV is incredibly common. I mean, most kids get it by age 2.
Right.
And for the majority, it's like a bad cold, sniffles, cough, maybe a fever. But for a small group, especially preemies or babies with certain health conditions, RSV can cause serious lung infections like bronchiolitis or pneumonia.
Okay, serious stuff.
Yeah, serious enough to need hospital care sometimes.
And that's where Palivizumab comes in.
Hmm.
What exactly is it, in simple terms?
It's basically a shot containing antibodies. Specifically, it's a monoclonal antibody, which means it's engineered in a lab to target the RSV virus.
Okay.
It's given as a monthly injection during the RSV season, usually fall and winter, and it helps prevent a severe infection from taking hold. It's purely preventative, though, not a treatment if the baby's already sick with RSV.
Got it. Preventative. So let's get into the specifics from that Georgia AAP guidance. Since the 2016 info just repeated the 2014 recommendations, what were the key groups identified in that first year of life?
Well, the main focus was on a few key high-risk categories. First off, infants born very prematurely, specifically those born before 29 weeks gestation.
Before 29 weeks, why is that cutoff so significant?
It really comes down to development. Babies born that early have underdeveloped lungs and immune systems.
Makes sense.
Yeah, their airways are tiny. They just don't have the reserves to fight off a serious respiratory virus like RSV effectively. They're much more vulnerable to severe complications.
Okay, so extreme prematurity is number one. What was the second main group?
Infants still in their first year who have certain chronic health problems. The guidance specifically calls out congenital heart disease, particularly if it's hemodynamically significant or chronic lung disease of prematurity.
Can you elaborate a bit on those? Why do those conditions increase the risk?
Sure. Hemodynamically significant heart disease means the heart condition seriously affects how blood flows through the body. An RSV infection adds huge stress to their already compromised system.
I see.
And chronic lung disease, often seen in preemies who needed oxygen for a while after birth, means their lungs are already fragile. RSV hitting them can be devastating.
So just to be clear then, for a baby born at or after 29 weeks who is otherwise healthy, Palivizumab isn't generally recommended.
That's correct. The guidance is pretty clear that for those infants born at 29 weeks or later, without these specific chronic conditions, routine prophylaxis isn't advised.
Let's dig into that chronic lung disease of prematurity, CLD, a bit more. Are there even more specific criteria mentioned for those babies?
Yes, there are. For preterm infants with CLD to qualify in that first year, they generally need to meet 2 conditions. Born at less than 32 weeks gestation, and they needed supplemental oxygen, specifically more than 21% oxygen for at least 28 days after birth.
Okay, so less than 32 weeks in that extended oxygen need.
Exactly. It targets those with a clear history of significant prolonged respiratory support.
And what about the babies with the heart conditions, the hemodynamically significant ones?
For them, the guidance says clinicians may give Palivizumab during the first year, but it stresses that this decision really needs to be made together with a pediatric cardiologist.
Specialist input is key there.
Absolutely. These are complex cases. The cardiologist understands the specifics of the heart defect and can best judge the potential impact of RSV and the benefit of the prophylaxis. They'd weigh things like the type of defect, whether surgery is planned, and a baby's overall stability.
That makes complete sense. Okay, let's talk logistics. How is it given? You mentioned monthly shots.
Right. For eligible infants in their first year, it's a maximum of 5 monthly doses during the RSV season.
5 doses max.
The dose itself is based on weight, 15 milligrams per kilogram of body weight each time.
And what if a baby qualifies but is born right in the middle of RSV season, do they still get 5 doses?
Good question. No, not necessarily. If a baby is born, say, in December, they might only need doses for January and February, depending on when the season ends, so potentially fewer than 5.
Okay, that makes sense. Now, what about after the first birthday? Is palivizumab ever used in the second year of life?
Generally, no. Prophylaxis is usually not recommended in the second year.
Usually.
Yeah.
But are there exceptions?
There is one important exception. It's for children who had that significant CLD needing at least 28 days of oxygen after birth, and who still require ongoing medical support related to their lungs as they enter their second RSV season.
Ongoing support
Like needing continued supplemental oxygen or being on chronic corticosteroid therapy or diuretic therapy for their lungs. It's a very specific group of toddlers with persistent severe lung issues.
Got it. Very specific indeed. Now, let's say a child is getting the monthly shots, but they unfortunately still get RSV and end up hospitalized. What happens then? Do they keep getting the shots?
No. If a child has a breakthrough RSV infection serious enough to require hospitalization, the palivizumab prophylaxis should be stopped.
Okay.
Because at that point, its preventative job is sort of over for that infection, and the focus switches entirely to treating the active illness.
Right. Are there any other, maybe less common situations in the first year where a doctor might consider palivizumab, besides the extreme prematurity or the specific heart-lung conditions?
Yes, the guidance does mention a couple of other scenarios where it may be considered. This includes infants with certain pulmonary abnormalities or neuromuscular diseases that compromise their ability to clear mucus from their airways. Think conditions that make it hard to cough effectively.
Okay, that makes sense. Airway clearance is key.
Exactly. And also, children under 24 months who are expected to be profoundly immunocompromised during the RSV season might be candidates. But these are definitely case-by-case decisions requiring careful clinical judgment.
And it sounds like there are also conditions where doctors just don't have enough evidence yet to make a routine recommendation.
That's also true. The guidance points out insufficient data for routine use in children with cystic fibrosis or those with Down syndrome. It doesn't mean it's never used, but it's not a standard recommendation based on the evidence available at the time. More research is needed there.
Interesting. The guidance also touched on geography, didn't it? Something about Alaska native populations.
Yes, it did. It noted that due to the higher rates of severe RSV disease observed in some Alaska Native infants, and also the significant challenges and costs of transporting critically ill babies from remote areas.
Right. Transport would be a huge issue.
Broader use of palivizumab might be considered for them, and potentially for some other American Indian populations facing similar issues. It acknowledges unique healthcare access disparities.
That's an important consideration. And just to double check, this isn't for preventing RSV outbreaks within a hospital, right? Like
Yeah.
if a baby's already in the NICU.
Correct. Palivizumab is not recommended for preventing healthcare-associated RSV. It's aimed at community-acquired infections in those specific high-risk infants before they potentially get exposed.
Okay, crystal clear. Since this guidance came from Georgia AAP, let's touch on the specifics for Georgia they mentioned back then. When did they say RSV season typically starts there?
They noted the season usually gets going in October. Based on the data from around 2014, the recommendation was to start giving palivizumab to eligible babies around October 1st.
And how long would the protection typically be needed?
Generally, up to 5 doses were considered sufficient, covering the peak season usually through February.
What about babies who are still in the hospital, maybe the NICU, when RSV season starts or when they become eligible? When do they get their first dose?
Good point. For those infants still hospitalized, the first dose should ideally be given 48 to 72 hours before they're discharged home.
Ah, okay. Gives the hospital team time to monitor them just before they leave.
Exactly.
And what about that last dose? Usually in February, you said. Are there exceptions if a baby is discharged right at the end of the season?
Yes, there are. The guidance said the last dose is typically February. But if a high-risk infant is discharged from the hospital in February, they should get a dose then and another dose in March.
Okay, so 2 doses close together at the end.
To provide that bridge. And if a high-risk infant is discharged in March, they should get 1 dose just before going home. It extends protection just a bit longer as the season wanes.
That's helpful detail. What if baby went home, is getting their shot, but then needs to be readmitted to the hospital for some other reason, and it happens to be when their next palivizumab shot is due?
In that case, they should receive the scheduled dose while they are hospitalized. No need to wait for discharge again.
Right, keep them on schedule.
Ugh.
And finally, for the doctors and nurses in Georgia, was there a way mentioned to keep track of who got which dose?
Yes, they mention that administered doses can and probably should be entered into GRITS. That's Georgia's immunization registry. Helps with tracking and continuity of care.
Excellent. Wow. Okay, that was a really thorough look at these guidelines. It's obviously complex, but so important for parents and caregivers of potentially high-risk little ones to understand this.
Absolutely. I think the main takeaway here is that Palivizumab is a very specific tool for a specific group of infants. It's about reducing the odds of severe illness and hospitalization in those most vulnerable babies. It's definitely not just general RSV prevention for everyone.
Which really underscores why parents must talk to their pediatrician. That conversation is essential to figure out if their baby fits the criteria, considering their unique health history.
Couldn't agree more. The pediatrician is the one to assess the individual risk.
Absolutely. And for you listening, if you want to find more detailed information on this topic or other resources about infant health and preventative care, please do check out omegapediatrics.com.
That's a great resource.
Again, for comprehensive details, the place to go is omegapediatrics.com. And if you found this conversation helpful, please give this video a like, subscribe to the channel for more health information like this, and maybe share it with other parents, caregivers, or even healthcare providers who might benefit from this overview.
Thanks for tuning in, everyone.
Yes, thank you. Goodbye for now.